the two candidates were presenting. So you both are from Bangalore, Hyderabad, or you're somewhere else? Yeah.
Both from
Yashoda.
Yashoda.
Hyderabad. Yashoda. Okay.
Just
Okay,
so
yes,
time is there now. We'll start.
Just a minute, sir. Madhu
Yeah.
sir, we are live now. We are good to start.
Yeah.
Finally, you are able to join, Justin.
Sir, we are good to start, sir.
Yeah, sure. Go ahead. So,
Thank you and welcome to our weekly webinar for the PG students for the case presentation, what we are conducting regularly on every Tuesday. Today's case discussion is there about the ACS and cardiogenic shock. For taking this case, the examiners are there, Dr. Ajith Kumar A K, who is the lead consultant at the Aster Whitefield Hospital, Bangalore. Welcome to you, sir. Thank you for sparing your time from the busy schedule. And the second examiner is there, Dr. Justin Gopaldas, who is the consultant at critical care medicine at Manipal Hospital at Bangalore. Welcome to you, sir. Thank you. Thank you for joining and taking out time from a busy schedule. And the today's case, what is there about the ACS and cardiogenic shock, going to be presented by our students, Dr. Udaykiran V, who is the final year of DrNB student for the critical care medicine. And second student is there, Dr. Vignesh M, who is also the final year of DrNB student of critical care medicine. They are going to present the case about the ACS and cardiogenic shock. Over to you, sir. Dr. Ajith Kumar, sir, and Justin Gopaldas.
Yeah. So, Justin?
yeah, so
Yeah.
I think they are going to start seeing the scenario, and then we will probably take it forward after after they read the first vignette or slide.
Yeah. So we will start from the basics. Yeah.
So 67-year-old male, rectal chest pain for 20 minutes or so, obviously classically cardiac, associated with the sympathetic signs like nausea, vomiting, and sweating. And so he's also got some unease, but there are no palpitations, orthopnea, or syncope. And he's obviously had a history of it for about a week, which we hasn't
Sorry to disturb you. Students will read about the case.
Yeah,
ask the questions, everything.
That's right. Yeah.
Vignesh, we can start.
Yeah, 67 years old male with the history of sudden onset rectal chest pain since 20 minutes. Presented at hospital. The pain was actually a dull aching type, which is relating to left upper limb with no variations in respiration, which is associated with nausea and vomiting and sweating as well. There is no history of palpitations, orthopnea, or syncope at present. And he claims to have an on and off chest pain and SOB on exertion only since 1 week, but he didn't take any treatment for the same. No history of similar complaints in the past. He's a known diabetic on metformin 500 mg and hypertensive on amlodipine 5 milligram PD, but he's not on regular follow-up for the past 20 years, or for the past 10 years at least. No other medication history has given, and he has no other history of any addictions as well, and he's a retired vendor by occupation.
So we'll stop there for that paragraph, and then I think Rajit will ask some basic questions after the initial history. We will come up with some.
So what is the life-threatening causes for sudden chest pain? Can you enumerate some life-threatening cause? This patient had a sudden chest pain. So I just want to know the life-threatening causes for sudden chest pain.
Acute MI and aortic dissection.
Any other thing?
Esophageal rupture.
Excellent.
Okay, you can have some other symptoms. Yeah. Any other thing? Chest pain.
Pulmonary embolism.
Yes.
Excellent. Yeah.
Any other cause? You can have life-threatening chest pain.
Pneumothorax.
Yeah, tension pneumothorax. Tension pneumothorax. Yes.
Yeah.
Okay, that's fine. Yeah.
So
this patient, no history of no other medication history, So what medication you are looking for actually? This patient?
So an old age male could have been on some phosphodiesterase inhibitors as well, pertaining to this case. So I was actually looking for that medication.
Mhm.
Okay.
Any other medication? Any other medicines?
Yeah.
Especially this case, you should be knowing.
In any previous MI history, would have the patient already be on statins or aspirin as well. That will also give a clue, though the patient may not reveal them.
Any other anticoagulants is already on.
Yeah.
We need to check it. Suppose if this patient is in, maybe in US, basically, you say US Colombia border. So any other history you may be asking?
Addiction is cocaine.
Addiction of what?
Cocaine addiction or anything.
Yeah. So Justin, you want to ask anything?
So I guess what we will just next, I think we'll go through the sequence just because this is not like a proper exam and it's like a practice for us.
Yeah.
The idea is that what Dr. Ajith is impressing upon is that as simple as a simple question like asking for a differential diagnosis, what he meant indirectly is tell me some differential diagnosis. And when you have a differential diagnosis, all he wants to know is that you're going to be able to give a structured answer. So
Yes.
there is an answer and there is a structure. So they are looking for both at the end of the day. So you could make a structure by saying that I'll figure out all the cardiac causes, the non-cardiac causes, let's say. And you approach in that way. And then it becomes easy for you to list out saying that, okay, cardiac, pulmonary, esophageal, and like a drug or other things like that. Or so things like that. So this is what when you get a structure, the answers become easy. Okay, so number one. Number two is that whenever there is an emergency, like Ajith just said, life-threatening, or you go to a Met call or a RRT or a code blue, you don't understand what the situation is. The first thing that you do is that just stop yourself and says 5 H's and 5 T's. You understand? You understand? Then it brings about the focus for you in terms of how you're going to answer the question. So this is what the exam is. So we practice this throughout this station, how we go through a little bit of structure before you answer. So take that 1 extra second, it's okay. And then you answer with the structure. So that's the plan. So the first slide is all about just understanding that it gives you a good feeling once you finish the session. Yeah. So we'll go through the next slide. Yeah. Now there are some examination has happened for this patient.
Patient is conscious, oriented, afebrile, no pallor, icterus, sinuses, clubbing, or lymphadenopathy. Patient's pulse is 53 per minute, which is saturating 95% on room air, with a respiratory rate of 26 per minute. The initial BP is 70/40. Patient has received one fluid bolus of 500 ml of ringa lactate, and he was started on NORAD infusion as well. And then the BP has achieved up 100/60 millimeters of mercury. All peripheral pulses are equally felt. And the pain score of the patient for the chest pain is currently 6/10. JVP is not visualized. Apex beat is at 5th intercostal space, middle to mid-clavicular line, and no parasternal heave has been visualized as such. And S1, S2 is here. No added sounds or no added murmur or no extra sounds has been here. Lung examination revealed bilateral air entry, no added sounds. Abdomen is soft and non-tender with bubble sounds, and no focal neurological deficit has been elicited.
So what does it mean?
Yeah. Now what Dr. Ajith is wanting is that you have some differential diagnosis before this. Now we're going to use this information to update the information. So that's the job. So now based on this, what would be your differential diagnosis is what Dr. Ajith is asking.
And with patient is having with a positive history of a chest pain and with a prolonged diabetic and hypertensive history, with a positive history of chest pain and having a low blood pressure and with a low pulse rate, probably in most probable causes, cardiac causes with possibility of a myocardial infarction is high index for suspicion should be there. And other things would be other cardiac causes like such as non-ST elevation MI and unstable angina, and maybe related to hypertension, maybe related to heart failure also. Maybe recent newly diagnosed heart failure also is a possibility.
So at this point of time, I understand the clinical examination says that all pulses are felt, but it doesn't rule out the dissection still.
Yes.
Yeah.
So why is not tension pneumothorax? I can see that, bilateral air entry is present. You have written this. So unlikely tension pneumothorax, and he is saturating around 95% room air. So probably unlikely. Yeah. So dissection, aortic dissection. Okay, you have mentioned the peripheral pulses are equally felt. Okay, that is fine. And so another possibility will be like myocardial infarction. Obviously, there is a possibility. We call it acute coronary syndrome. So this could be it can be an ST elevation myocardial infarction, non-ST elevation myocardial infarction, and even the so-called unstable angina. So
Yeah.
so that's it. Yeah.
So what we have done with the second slide is about for each step of sometimes with the vignettes given, maybe you would go through all these things at the same time, or sometimes when you're presenting the main case, suddenly the examiner would stop you from just the main history and presenting history, and then say, now tell me the differential diagnosis, and then they will say, okay, fine, tell me the findings, then again ask you to, and then tell me the investigations, now update your differential diagnosis. So this kind of stop-start are one of the strategies some of the examiners use. And that's why I just wanted you to be aware of that. Sometimes you can go through all of this and then they'll say, okay, tell me now, after you finish your examination, tell me your differential diagnosis. So you should be able to synthesize differential diagnosis for each step or at the end also. So that's at the end of the day, the practice is all about how we get through the exam, even if you know or you don't know the case. So at the end of the day, we are given a case in the exam. So you can see every single piece of information, isn't it? It's not like old days, like an MD exam, you don't know what the case till the last minute. Here you are given every piece of information. So the reason why they are giving it is because they want to see from you something that is not there in the notes, which is how you interpret. So the exam skill is all about how good you are about interpreting a question. So he says differential diagnosis and how I'm able to frame it for him. When there is a new information, how I've been able to change it. So this is what the examiners are looking for. Otherwise, like they have given everything, isn't it? The diagnosis is also written at the top for that day. Plan is also written on most of the days when you go to see the patient. So what their examiners are asking for is something different than what it is written there. So that's the sequence of events we just wanted. So just initial slides are just about, it's not like teaching, but just so that you make the next questions are a little bit more for you to feel up to it and frame it. Yeah. We'll go to the next slide. Yeah.
So this is the ECG, which is taken at 5 minutes of arrival. So this ECG depicts ST segment elevation in lead 2, 3, and AVF, and ST segment depression in V2. Which essentially states the patient is having an inferior wall MI.
Yeah. So obviously, Ajith probably may want you to read the ECG maybe in a little bit more detailed fashion, let's say.
Yeah. So when you do an ECG, as per the international protocols, to diagnose an ST elevation myocardial infarction, what is the time frame you are supposed to diagnose do an ECG and diagnose the thing on the spot, spotly diagnose the ST elevation myocardial infarction? What is the time frame?
The ECG interpretation should have been done by the end of 10 minutes from the first time of contact.
Yes, so that's the thing. So basically, from the emergency, the patient is coming to you for the emergency. Obviously, you have to see that within 10 minutes you have to do an ECG. But every time the ECG may not be there everywhere, but it all depends. So you need to have the ECG done, interpreted within 10 minutes. So you do the ECG in 10 minutes. So here you are telling there is some kind of a ST elevation somewhere, is it? 2, 3 AVF. No, I understood that. Some ST elevation is there. Am I right?
Yes,
Yes, sir.
So how will you which are the criteria? How will you diagnose, what are the criteria to diagnose ST elevation myocardial infarction? I mean to say, what are the ECG criteria? Means like what are the ECG criteria?
So ST segment elevation of more than 1 millimeter in all the leads except B2 and B3, where we look for ST segment elevation in females it is 1.5, and in males less than 40 years it will be 2.5, and more than 40 years it will be 2.
Yeah, I will say that maybe around.
It should be a contiguous leads actually.
It's issue with the number one is it should be ST elevation myocardial infarction should be diagnosed. You have the ST elevation number one, as you said, you should have this 1 millimeter rise has to be there, and V2 and V3, as you already mentioned, should be 2 millimeters, generally 2 millimeters, and it should be contiguous leads. Any other apart from the ECG contiguous leads, two contiguous leads, two or more contiguous leads, which is there any other criteria how will you diagnose ST elevation myocardial infarction?
Other thing is posterior infarction can be also present. So posterior infarction or right ventricular infarction will be 0.5 millimeter elevation, either in V7 to 9 or in V3 and V3R and V4R also can be used.
Any other criteria how will you diagnose myocardial infarction?
And new onset LVBB.
Yes. Any other criteria? Any other criteria? Because these are life-threatening criteria, which is supposed to be annoying. Non-ST elevation features will be there, but you have to treat like a ST elevation myocardial infarction. Any other diagnosis
ABR. One in ABR, if there is ST elevation present, we can treat it as an
any other too dangerous syndrome. Just for discussion. Any other it's extremely rare. See, common things are common in medicine. Rare things are rare. Just for discussion.
Tall T waves, hyperacute T waves in V2 and
no. What I mean to say that someone is Wellen syndrome. Wellen syndrome is basically you can have biphasic T wave will be there in V2 and V3. Sometimes it will be biphasic T wave. Sometimes there can be T inversion will be there. So the problem is that these patients within patient is most of the time when you have this inversion by the biphasic T wave, the patient will be pain free. So patient may not have any pain enough, patient is okay. But these kind of patients can rapidly progress into infarction within a few hours to days or whatever, hours to days. Basically, there is a very likely these kind of patient, Wellen syndrome, you can Google and see, there is not much time to discuss. But if you most of the time may be in the proximal LAD. So you need to do an urgent evaluation, coronary evaluation, and you have to go for a urgent PCA may be required. That is Wellen syndrome, WELLEN syndrome. Other thing is Dale winter sign. That's just for academics say again, WINT, Dale winter sign. So there also you can have some kind of a third period will be there, and maybe on V2 and V3, and sometimes you can have the depression, upsloping depression or that ST depression will be there. There also the thing is that important to see that these are all non-ST elevation thing, but you are going to treat the non-ST elevation of coronary scheme as a ST elevation myocardial. You go for a patient has suddenly developed a myocardial infarction. Again, the block is very likely in the proximal LAD. So Wellen syndrome and this Dale winter, at least you should know. Though as I already mentioned, the common things are common, rare things are rare, but we need to be aware of that. Sometimes the patient can come to the emergency. Patient may be painful. You cannot wait for further evaluation because you need to act immediately. That's what I want to convey you.
Yes.
So whenever there is an MI particularly, and then there are what is called as a positive findings. So you can get to the diagnosis first. So ECG is in keeping with the inferior wall MI. Maybe there is a component of posterior wall infarction. You can say that. But there are one or two things that are more important. You would think it in a case you will see the ECG and look for heart blocks, particularly when there is a problem. You understand, sir?
Yes.
Yeah.
So when you say that the ECG doesn't have any evidence of heart block, which means that you have assessed the patient to possible complications as well. You understand, sir? So that gives you an extra credit point for you to have read it in a fast way, but at the same time you made something that is very important that a cardiologist or a CCU doctor seeing, they generally that's what they're looking for, heart block, bradycardia is there.
So in this yeah. So in this ECG, so what are the changes you mentioned? Where are the changes?
ST segment elevation and lead 2, 3 and AVF.
Anything else is there?
Reciprocal changes in
AVL is also.
AVL and V2, lead V2.
So what does it mean? So can this be patient if having a posterior wall extension?
Yeah, I think they've mentioned that. I think possible.
Okay. Yeah, that's you can you see you are looking at for a ST depression. Classically, they say horizontal ST depression, but even in this case, you can have some ST depression in V1 and V1. One of the other things, there's a subtle ST depression is there, and the tall R wave is also there. So very likely this is going to be inferior wall MI with a posterior wall extension. And what is the so-called reciprocal changes? Where do you reciprocate the changes? So when you have an issue in the 2-3 AVF, where is the reciprocal changes are going to happen?
Generally, 1 and AVL, there will be reciprocal changes.
So where will be reciprocal changes when it's in? So what is V1 and V2? V1 and V2 is representing what?
It is representing the septal.
Septum, yeah. So when you have an issue in the V1 and V2, where is going to be the reciprocal change?
V6, sir.
No, it is 7 to 9, the posterior wall. V7 to V9. So V1 and V2 is a septal area. That is the thing. So when you have the reciprocal changes, so many people misinterpret because many people believe that now 2-3 inferior wall, they will reciprocal change the anterior wall. That is not the thing. So you go for 1 and AVL. So V1 and V2, that is representative septum, and you can have the changes from V7 to V9, that is the posterior wall, and V3 and V4 is the anterior wall of the left ventricle. Obviously, there is no reciprocal change. You don't have a reciprocal changes are not happening. And V5 and V6, that is, the apical, the apex, or I guess the lateral wall and apex, I will say. So there, the reciprocal changes are going to be in, 2 AVF, 2 AVF. So V5, V6 and 1 AVL, these are in a lateral, 1 AVL is high lateral, you know that. So then you look for the reciprocal change in 2, 3 AVF, 3 AVF will be the reciprocal changes. So that's it. You should know where the reciprocal changes are happening. That's what I want to convey you. So that's it. So you are the physician in the emergency. Any other information, man? Nobody's, okay, ECG, okay, you believe that there is a inferior wall MI within probably a posterior wall extension. I can see there is a tall airway there. I mean, some kind of a subtle depression I can see there. So any other thing you can get from the ECG nowadays, the modern, emergency medicine, the critical care?
We can.
Any other things are important looking at the ECG? So what is your diagnosis in this case?
Which artery involvement can be picked up from the ECG as well?
Okay, so which are the artery which can be involved in inferior wall?
So it can be either RCA or it can be circumflex.
So left circumflex.
Yeah.
So RCA will be there and maybe around 80 to 85% of the 85 to 90% of the cases, I will say. Maybe 10 to 15 cases, it could be the left circumflex. That is one thing. So which is supplied. Any other information? Secondarily, you can also identify where is the block. If it's a very proximal block of the major arteries, so the problem is that you are going to have a significant myocardium at stake, isn't it? Because you have a major block proximity. So you see, number one, as you rightly said, you need to interpret the ECG and find out, in this case, the inferior wall MI. So as I mentioned to you, because 85 to 90% the inferior wall MI will be predominantly the RCA, around 10 to 15% will be the left circumflex. You need to identify what it is there. So for that means you should know, you should have, you look at lead one, because, I think the criteria are, is a bit, thought-provoking for me as well, because, we used to make a chart, we would like to have a chart about that. So basically you look at lead one, and you look at, there you can find out whether it's a predominantly in a left circumflex or an RCA. Then you look for V4R. V4 over here not taken because there is one lead is very commonly missed in these situations. So when you look at the V4R, so then you will be able to see whether it's a proximal or distal. So what is the importance of whether it's a proximal or distal in inferior wall MI? Dr. Uday? If it's a proximal RCA occlusion, so that means it is before the RCA, the right ventricular branch is given, then before the right ventricular branch is given. So occlusion is proximal to the right ventricular branch. So if it's a proximal RCA occlusion, what is going to difference?
So there will be a bundle branch blocks will be more common, and heart blocks will be more common with proximal RCA occlusion.
Yeah, proximal RCA occlusion is before the branching of the RB branch. So right ventricular infarction is going to be the patient can have hypotension, patient can have bradycardia. All these automatic, disturbance also will be much more common. If it's a distal RCA
again can be noticed with the
So if it's a distal block, maybe it should be less mild. So you have, depending on the ECG, if you interpret which vessel it is there, where the block is there, even for LAD also the criteria are there. Obviously I don't think verbally we can discuss, except that it's a large criteria. It is given in any of the standard cardiology textbooks and all. So you'll come to know, because those kind of situations, if we can identify early, what is going to happen is that if the patient happens to be a tertiary center, for example, patient need to be shifted to another place. We know that the current myocardial, MI guidelines, AHA guidelines are telling that you need to, whenever a patient is coming with, you diagnose, myocardial acute coronary syndrome, ST elevation myocardial infarction. So you need to send to the nearest place, where you can do a PCA within 2 hours. That's the thing what we are doing. So we send the patient. So these are the conditions. But the studies have shown that when the blocks are going to be more proximal of these major arteries, especially I'm talking about, the left anterior descending artery, the RCA, even the circumflex may not be that bad, but still, even the left circumflex artery, when the block is more proximal, the problem is that the myocardium at stake is going to be large amount. For example, left anterior descending branch, it's a major artery of the heart, I will say, in the sense, what I mean to say that almost 45 to 55% of the myocardium is, under his control. When the LAD is blocked, you can see that in how much myocardium, more than half of the heart is going to be stake, 55% is going to be stake. So those conditions, the consideration is that you can even thrombolize the patient and then send the patient to the nearest place for a PCA. That is important. So that's what we get from that. So this appears to be an inferior wall with the posterior wall extension to me. And obviously, as you said, looking at the other criteria, you need to find out whether it's a proximal block or distal block.
Yes.
So Dr. Justin?
Yeah, so I think we'll move to the next slide.
Yeah. And another thing I want to discuss with them is that, see, whenever you diagnose an ST elevation myocardial infarction, which are the 4 dangerous signs where you need to rule it out. It is not really dangerous, I know, but in the sense, obviously they are life-threatening signs. Which are the 4 life-threatening aspects you need to look at once you diagnose ST elevation myocardial infarction? Number one is heart failure. Number 2, cardiogenic shock. This patient, obviously, there is a cardiogenic shock has come. Number 3, as I already mentioned to you, you need to rule out, the aortic dissection. So aortic dissection, number 1, is an extremely rare condition. I would like to say it's a rare condition. Number 2 is that the chance of ST elevation myocardial infarction, in aortic dissection also is around 1 to 5%. So what I mean to say is that it is rare, but the problem is many times this has been misdiagnosed. Even after people start with myocardial infarction, after 2 days, they'll come to the aortic dissection. So aortic dissection also you have to keep it in mind, though it's a rare complication. Third thing, very important thing is you have to take a proper history of the patient, what kind of an anticoagulant he's on, any kind of a coagulopathy he's having, even in the form of a low platelet or anything, so that, because that is going to determine, what are you going to do. So that is what you're going to do that. Yeah. So these are the 4 things that you quickly look at it before we proceed. Yeah. Yes, Dr. Justin.
So I think what we will do now is that maybe we will just ask them to see how they would proceed. Maybe we will start with Vignesh. Vignesh would answer. Okay, now we have got what we call as a history, examination, and initial evaluation. So how are you going to proceed with the patient? So now I want you to explain how would you proceed.
So starting from airway, breathing, and circulation, look at the patency of the airway. And
before that, there's an ST elevation myocardial infarction. No, I'm sorry, because since it's a teaching session, I thought I'll add to that. So with ST elevation myocardial infarction, you are diagnosed, and you are in a peripheral center in Karnataka. You are in the periphery. So what are you going to do? That's all I want to know. You are the person in the primary center. You are diagnosing a ST elevation myocardial infarction in this patient. If you develop MI. So how are you going to proceed as per the ACS guidelines?
Yes. If PCA center is nearby,
yes,
directly send the patient after loading with antiplatelets. If PCA center is
nearby, how nearby? How nearby? Nearby means what?
Sir?
How nearby? How nearby?
Actually, within 30 minutes, if patient can be transferred to the.
I would like to say that if the patient is having a ST elevation myocardial infarction, you diagnose, and you are able to, obviously, that the treatment of choice for any ST elevation, obviously, at this point of time, we go for PCA. But obviously, when you are in a rural primary center where you don't have a PCA facility, you send the patient to the nearest PCA facility. You can refer the patient to the nearest PCA facility. If the PCA facility is accessible within 2 hours, 120 minutes. I just want to say that 120 minutes. If you are unable to, if that's one thing. See, there are 2 considerations. Number 1, obviously, you have a PCA center in the nearby within 120 minutes. If you are able to do the PCA within 120 minutes, you can send the patient to the nearest place. Number 2 consideration is that One is about the PCA, whether you can do. Number two is that whether the patient is having two things you are considering. Patient is having cardiogenic shock or not. Then if the patient is having a cardiogenic shock, without doing a PCA, the mortality is going to be around 70%. So these are the patients where you need to send to the PCA place. When you go to the PCA place, you have to ensure that you get the PCA done in both the cases within, cardiogenic shock in the earliest possible, obviously. But as you said, in the sense, as you said, within 2 hours, you should be able to do the PCA. You should be able to do the PCA. The 2 hours is important. If you are not able to do the PCA, if there is no nearby center, within the 120 minutes, you are not going to 2 hours, 120 minutes, you are not going to get a PCA center nearby. So what you do, you can consider fibrinolysis for the patient. For the fibrinolysis, what they're going to do is that there is also some timing is there. Whether it's 12 hours or less than 12 hours or more than 12 hours. If it is more than 12 hours, the symptom of onset is more than 12 hours, then the fibrinolysis is not unlikely to be useful, because by the time so many damage would have happened, it is very controversial. Number two, if it's less than 12 hours as elapsed and you are unable to find out a center, which I already mentioned, PCA center, then you can thrombolyze the patient unless unless there are any contraindications. So you have to try for thrombolysis. Again, you can ask me then why the patient with a shock can be thrombolyzed or not. Patient can shock. Basically, studies have shown that even if you thrombolyze, it's not going to be really effective. But if the patient is within 3 hours of symptoms and all, these patients also can be thrombolyzed. If there is no other options are there. But obviously, in a patient who is having a cardiogenic shock, being the treatment of option is PCI.
Yes.
Primary PCI, yeah. It has to be there, yeah. So what I will say that the 120, the time frames are very, very important. Before, these kind of time frames are just to guide the thing, I know that, but if you are able to do the PCI, get it done, you are able to do within 2 hours or not. That is the question now. If that is happening, you have to send the patient there. Cardiogenic shock patient, irrespective of whatever is there, you have to send the patient. Because, it is irrespective of the thing, at the earliest possible, you are trying to save the patient has gone for PCA. If you are not able to do it, the facility is not there, you have to think of a thrombolysis or fibrinolysis. If it is more than 12 hours, you can't do anything. Less than 12 hours, you fibrinolyze the patient. Obviously, you have to closely monitor the patient. You look for, whether the patient is in ST segments, hemodynamic stability is there or not. If it is not happening, again, you have to go for a PCA center. Obviously, you have to shift the patient to the PCA center. If it is a patient is settling, things are improving, ECGs are getting better, hemodynamics are improving, and the ischemic pains are reduced, obviously, then you can again, at the end of the thing, you have to go for a PCA center. Maybe in the second case, the patient is improving fibrinolysis. The fibrinolysis obviously you can wait up to 24 hours. Even then ideally within 24 hours, you have to go for a PCI, I hope you understood what I'm trying to say.
Yes.
So basic cardiogenic shock. Okay, you can ask why the thrombolysis.
We'll come to that in this next session. Yeah.
Yeah.
So they'll just now, based on the information, they're going to synthesize and make a plan now. Yeah. Vignesh, go ahead.
So initial starting with airway breathing and coming to circulation part of view. If the BP is not maintained, we'll give a fluid bolus, and we'll look at the JVP as well to take care whether to rule out the patient is not having an RV infarction, where we have to give a judicious amount of fluids. And, if the circulation is still not, the BP is not maintained, the first vasopressor of choice is going to be noradrenaline for me at this point of time. So once these things are established, then I'll go and load the patient with the aspirin, non-entry coded aspirin of the 25 milligram. And since this patient is having an STMI and my center is going to be a PCA, primary PCA center, I'll load the patient also with heparin, 70 units per kg, and tegagrelor of 180 milligram loading dose, and I'll plan to ship the patient to a cath lab. And pain control as well. I'll give a morphine or a paracetamol combination as well for this patient.
Yes. So if you are, Jesse, can I ask some questions? These are all very basics, man. Can I ask some questions?
Yeah, no, I'll let you ask next.
No problem. Yeah, no problem.
So now at the end of the day, so I wanted you to define the shock for him. Now you said patient is in shock. So I want you to define the shock.
So to define cardiogenic shock, the system.
No, just a shock. Shock.
Demand supply mismatch.
Tissue perfusion.
Excellent. Excellent. Which is leading to
And
an
increased
organ
endorphin
dysfunction.
perfusion.
Endowment function. Yeah. So that's one. So now come to the cardiogenic shock. Now I want you to define the cardiogenic shock.
Systolic blood pressure of less than 90 millimeters of mercury, or a decrease in MAP more than 30 from baseline.
Yeah.
And also a decrease in cardiac index of less than 2.2 with supports, or less than 1.8 without supports.
Excellent. So that's this is marginally different from septic shock. So let's say if you thought that a distributive shock is there, so how would you differentiate a cardiogenic shock from a distributive shock of any cause?
In a cardiogenic shock, the pulse pressure will be narrow, and in a distributive shock, the pulse pressure will be wide, sir. Most probably in distributive shock, there is other history like suspecting pertaining to other infection. It can be seen.
And periphery is going to be warm in a distributive shock, as which is going to be cold extremities. And if we have a pulmonary capillary wedge pressure, the pressure is going to be less in case of a septic shock or a distributive shock, versus cardiogenic shock will have an high pulmonary capillary wedge pressure.
Excellent. So what we'll do is that I've asked you 3 questions. So we'll just go through this again one more time. So the first question was, I wanted you to put it together and make a plan, or else come up with what we're going to do. So at the end of the day, say this is a case of acute inferior wall infarction with a cardiogenic shock, for which my plan at this point, as long as, because his airway and circulation are adequate, isn't it? Like he's breathing okay. So my action is to optimize the circulation. So what do you guys do generally when somebody is hypertensive in ICU? What would you do? I understand we all give, like, most of the registrars on the floor give a half a liter and we'll come back and see. I know, but that's not science, isn't it?
Yes.
So we do something else, which we should be doing practically every day, but sometimes because of the laziness, we don't do it. But now that's what we want you to do this. Maybe when you go back for the next 3 months before exams, when you keep doing it every day, then you'll realize hypotension is a significant event. So your assessment is not just about giving fluid bolus. So you want to assess what we call as the 2 aspects to a hypotension, or in turn a shock, is volume distribution, volume demand or preload, and then the cause of the shock. So there are 2 things that needs to be assessed. Yeah, it is possible that this patient may or may not have cardiogenic shock. So for us, I want to know that you tell me that the patient has got a volume or not, or the type of the shock, that based on whatever investigations that you have in your hand. So when you tell me this, then I know that, okay, fine, at least you may proposedly say that it's cardiogenic shock, but at least you're making a case. You understand? So yeah, so that's what sequentially, when you answer to me a question, that's what I'm expecting as an examiner. The next thing is that then you would go ahead and do certain things, like, whenever you assess and come up with your priority, then either giving fluid based on certain things, or like say I use wedge pressure, which is not there, but most of the time we use echo, B lines, and then IVC, and then start giving some fluid and keep seeing whatever mini fluid bolus or bigger fluid bolus based on the clinical scenario, and you're doing that. So that's generally for us what the plan of action is, and that's what I want to hear. Number 2 is that you now have to tell me the type of the shock, like is LV down or not, or are there any other features to suggest that LV function is slow, or whether you could measure cardiac index or VTI and cardiac index based on this, and then measure and tell me that it's a cardiac index, to prove me that this is more like cardiac rather than some other cause. So this is what the expectation for the examiner, which is not written in your case sheets anywhere. You understand? Now you are getting the point, isn't it? You are given every piece of information about the patient, but examiner wants something else. And that's exactly what you need to tell me. Yeah. So the second question is that I said, when you say, how are you going to address this problem? So we launched into something. So The same thing, if I have asked you in ACLS situation, you would say, concurrently, I would assess airway breathing circulation. You understand? The word that would come up is that concurrently or designate and delegate. So at this point of time, the main thing is that he needs to get a reperfusion strategy. Decision to reperfusion may stand with you, but the performance of the procedure as an intensivist or an emergency doctor is not done by you. So you say that now that based on this, generally the code STEMI, most of hospitals have it. The minute you say code STEMI, the system runs so fast. I'm sure that's the reason why code STEMI, code stroke, code sepsis, all these things that come up in the system is because the minute you say that, the following events are like, you don't have to even say something, so it'll just happen. Patient gets loaded, cath lab staff will come, keep ready, some consent sheets come, everything will happen. So this is what I want to do, is that be mindful when now you know the scenario, but I'm not hearing what I want to say. This is a code stroke, code STEMI scenario. And I wanted to raise a code STEMI and if possible, get a cardiologist as soon as possible to make the plans. And based on that, we will take a call. And during that time, my chance is to continue to resuscitate this patient who's suffering from cardiogenic shock from an acute MI. So this is what I wanted to hear from you from a second point of view, in terms of what is called as a concurrent management plan. Yeah. The third one is that when I said these are the common examples of the exam course, even in exams we'll write. So differentiate between two. So when you write to differentiate, suddenly in your mind, you write a flow diagram saying that cardiogenic, distributed. And then on one column, you have history, examination, and advanced investigations, and then assessment. So when you do that, then you'll write history of fever or septic features, history of chest pain and cardiac history, or examination features, infective focus on it. So this is what I meant to say is that when you are answering, when a formatted answer or like a more structured answer, or the way how you're answering, like somebody says that, how would you differentiate one to other? Means that suddenly in your mind, you say, okay, I need to have this tabular form, and it becomes easy. So you know the information. It's not like you don't know the information. It's just answering pattern is one of the main ways why you get into a lot of trouble. Then they'll start asking questions. You go from fever to wedge pressure to peripheral pulses to white pulse pressure to capillary refill. So it goes up and down, So it looks like as if you are like whatever comes to you are shooting from the hip, the word is called, yeah. So that is not what is expected. So we have spent 3 years in a critical care training program, and we wanted to be finesse. We want to be smooth about it, and this is what I'm saying. So these are the things that we are impressing upon you, is that how to answer in a structured way and what are the basic things that are required. This is the first vignette. Technically speaking, we have just about come to the end of the first vignette. This would have taken probably no more than 3 minutes or 4 minutes. So they would ask whatever I asked, like 5-6 questions that we have asked. And in 3 minutes, they will just rapid fire. They'll keep going on. And then sometimes the minute you start saying, they know that you know it, and they'll move on to the next thing. So getting that finesse, not just about answering, but how to process the information quickly is the name of the game. Okay. So we'll go to the next slide. Yeah.
And we have given the patient with aspirin of 325 mg, sir, and ticagrelor of 180 mg, with a tablet atorvastatin of 80 mg, sir. And injection heparin we loaded with 5,000 international units in IV. And to control pain and relieve anxiety, we are given fentanyl with 30 mics plus 20 mics in a staged manner. And we are done at bedside 2D echo, which is showing hypokinetic inferior wall of left ventricle and no RV dysfunction. And initial ABG is showing hypoxia with the type 1 respiratory failure with a PaO2 of 65, and with there is a lactate with a decreased perfusion marker which is raised with with a point of 2.21, which is raised. And baseline investigations with the hemoglobin of 14.7 and the platelet count of 3.3, INR of 0.9 and creatinine of 0.8, and electrolytes potassium was 4.5, and tropi was elevated, significantly elevated, that is 6. Yes.
Ajay sir, kindly unmute sir.
Sorry. Yeah, that's the thing. Yeah. So that's it. So coming to the now I think we are dealing with a cardiogenic shock. We can go further. So before that, I just some basic thing just want to cross check. So the aspirin, suppose you are unable, you are supposed to give a non-entry coated tablet to be chewed by the patient. That is the way it should go. Any other option if the patient is not able to take aspirin through the mouth?
IV aspirin.
IV aspirin, I'm not very sure. Some of the American literature, talking about rectal aspirin, 600 milligram rectal aspirin. Some of the studies have shown that it is as good as this one, but I don't think I never used that. But just for information, I'm telling. So aspirin you are giving. So initially, regarding the oxygen, so you give aspirin, that is number one. You do that. You give atorvastatin, 80 milligram. You are given there. So for the pain control, you are give for the pain control. What are you going to give now?
We have given fentanyl.
Yeah, that's yeah. So that's okay. So people used to say that you can give morphine around 2 to 4 milligram. The morphine was in every 5 minutes was recommended. But obviously there are some concerns, theoretical concerns are there, because number one is that there is some sort of it can inhibit the ticagrelor sort of thing, that is P2 yeah, P2L12. The inhibitors can inhibit. Some concerns are there. So many people give for instead of that people prefer for the pain. People prefer more of NPG, nitroglycerin. Nitroglycerin is people are preferring for the pain now. But again, for the nitroglycerin thing, again the issue if the patient has significant pain means. So again, the issues are you have to be extremely careful. The patient who is already having a RV infarct, patient is already having hypotension, aortic stenosis, people who are on phosphodiesterase, the sildenafil citrate, those kind of patients, and you can have significant profound hypotension with nitrates. Then you need to be there. Third thing, but oxygen. So the oxygen also, there will be a lot of, a little bit of theoretical concerns are there about oxygen. There are 2 trials. One is about the detox trial, you may be knowing. Yeah, and the AVOID trial. Basically, so based on the trial, at least the AVOID trial has shown that there is the increased chance of, myocardial scarring with a cardiac MRI in those patients whose oxygen was kept high. So basically, you are looking at a saturation of around 94%. The patient is having a saturation of 94% or more, there is no need to give any oxygen. That's what I want to convey you. And ticagrelor and obviously pasudotox are preferred over clopidogrel. So number one, they are more potent. Obviously, the platelet inhibition also going to be very strong. For example, the ticagrelor can inhibit within 30 minutes, it can inhibit around 40% of the platelets. For the same thing, the clopidogrel will take around 8 hours. So naturally, it is fast acting as well. So that is what it is. So now, Justin.
Yep.
Yeah. So we'll go to the cardiogenic shock now. Yeah.
Yeah. So the next, I think there is another slide, isn't it? We'll just move to the next slide if you want. Yeah. So obviously he's had the procedure done, and so I guess the intensive care doctor who's been with the patient managed to go with the patient to the cath lab as a support until other support systems have come. And this is what he's seeing. So let's say, do you have another slide after this? Yeah, we have another slide. Yeah.
Yes.
Next slide. Yeah.
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 So before that, yeah. So what are the mechanical complications of a myocardial infarction?
Can be a ventricular septal defect, papillary muscle rupture causing MR, or a free wall rupture,
causing
cardiogenic shock,
and arrhythmias.
Mechanical complications,
Ventricular septal rupture and free wall rupture, and mitral regurgitation secondary to papillary muscle involvement. So okay, so this patient, okay, you are taken for a
what has happened actually? RC occlusion. Okay, now there's an RC occlusion there. Is it a proximal RCA?
Yes, sir. Proximal
Yeah,
ACS.
Okay, so stenting is done, you mean to say?
Yes, sir.
Okay.
So okay, you are given in inotropes, you are given fluids. Any other thing you can consider for cardiogenic shock? Any other considerations?
And actually, our patient is improved with noradrenal support after revascularization. There is significant improvement in hemodynamic status. Sir.
Okay.
Uh,
We'll just move to the next slide if you don't mind. Yeah, there is one more slide, I think. Yeah. Okay. So patient is moved back to the high dependency or ICU or CCU, one of the units, where you are there now. The ECG looks like this. Everything looks fine now. He's still on NORAD. Okay. So, but after about 3 or 4 hours, he started complaining a little bit of breathlessness. And by the time you went to see the patient, the noradrenaline is running at 20 ml per hour, or a lot more than, or what we call as the dose which is considered to be high. Yeah. So now suddenly heart rate is about the same, BP is about the same, but now you are giving almost like a 4 or 5 times what you are giving noradrenaline. And patient is complaining uneasiness and some breathlessness. So how would you now go about with this patient?
To look for any stent thrombosis. Other thing what I look for is mechanical complication. Anything has happened. I'll be evaluating those grounds.
Yeah, excellent. So obviously, I want you to go through with what all things that you will do now.
Okay, I'll do a bedside echo, quick echo, to look for any mechanical complications such as free valve rupture causing any tamponade, or any MR, new onset MR which is happening, or any VSD which is new onset which has happened, and those causing and worsening of the shock. At the same time, I'll be repeating my ECG as well to look for any fresh changes as compared to this ECG.
Very good. Yeah. So
and
ECG.
And if there is no mechanical complication, I'll again take the patient back into the cath lab, look for patency of the vessel. Okay. The second thing. So now, obviously, again, the whole point is, so there is a change in the clinical scenario. So whenever there is a change in the clinical scenario, the ideal would be that I just make sure that his respiratory state is okay. So patient is still awake. So that you really want to address whether there is any higher oxygen demand or whatever. I mean, there's no oxygen given there. So you understand what I'm going to say? Is the patient going into cardiac failure or not? So this is what we want to do. So again, you do what is called as a appropriate ABC. You don't have to say ABC each time, but you say, because of his breathlessness, I will address the breathing problems along with the circulatory state, get him some oxygen. And then whilst I'm assessing cardiac state, I'll call for an ECG, ask the cardiologist to be made aware, get an echo machine, and I clinically examine the patient, which is what you do. And again, now that the shock is worse, what I'm expecting you to do is that assessment of the shock. So now you again have to prove to me that he needs water or not, or the shock, is it purely cardiogenic or something else is happening, like in obstructive shock. So these are the things that we want to know. So at this point of time, I say, I will do a echo. So echo is echo, technically speaking. We all supposed to be doing what is considered to be a structured assessment or focus, not doing echo ultrasounds. So we do FAST, Blue Protocol, or Sesame, or one of these things, isn't it? Like, at the end of the day, these are the things, or eFAST. So whichever that you could get the life-threatening problems and for you in terms of assessment. So that's what we want to hear. Yeah. So at the end of the day, echoes are not reported by you. Echoes are done by somebody who has got a lot more experience. But you are experienced to do eFAST. You've done enough. So you're competent, actually, more competent than a cardiologist. So these are the things, the small details, but I would do a quick eFAST. Doesn't matter. Like, for you, all you need to do is that you put a probe on the body. So that's what I'm saying. A structured approach to the patient is what examiner is looking. Okay, we come back through. This is like a practice. What I'm going to say is that
But what I'm going to say is that we don't practice this on a day-to-day basis. And that's why we just sort of say something as if it is not like in a simulated scenario. But this is not simulated scenario. This is real. Like, the people get sick. Like, some urosepsis comes in, and 2 hours later, suddenly patient is on vasopressin and NORAD. You don't even realize. Some senior nurse is trying to titrate the BP. You turn up and say, like, what's happened? You didn't call me. So it happens all the time for us. And you don't just say, okay, fine, give some fluid and get something and we'll do ultrasound. So this is what examiner wants to hear from you, is that you are in tune with assessments, structured assessments. Okay. So now let's, for example, think that there is a new LV dysfunction, like you said, and then the cardiologist comes and says that the ECG is about the same. There is a sort of probably there was another vessel that may be involved, but at this point, I don't want to take him to cath lab. So optimize him, and then I will come back in 60 minutes. So what all things that you can do to optimize him?
One that I'll again look for, since the patient is already tachypneic, so I'll look at the oxygen status. I'll supplement oxygen, or even better, if the patient is already in failure, I'll start the patient on NIV at this point.
Excellent.
Secondly, when I come to circulation, since the patient is having an worsening shock with increasing NORAD requirement, I'll consider putting an IABP at this point to maintain the circulation until the cardiologist comes back inside and take up the patient for
excellent escalation of your circulatory supports. Excellent. Yeah, that's good. So, and then reassessment of your organ dysfunctions. Okay, so passing urine or not, other supplies are happening or not. So these are, for us, you want to make sure that the other organs are well. So I'm sure you would have seen with your patients' families, you would have spoken, urosepsis, the patient is shocked. You say, BP is getting better. Then the only question they will ask, other organs are okay now?
Yes.
So, so it looks like as if it is a very simple thing, but actually everybody wants to know. The cardiologist also says the same thing. Are other organs okay? You understand? So this is a holistic approach to the patient care in terms of how you assess and interpret is very much important. And is exactly more like, it is not like you need to say everything all the time in the exam. What they want to do is that they want to know whether you're able to connect the dots. Ajith's commonest statement is awake and oriented. So that's what they want to hear. Yeah. So now we have escalated to IABP. Let's say you managed to get an IABP in with the CCU specialist registrar, and you managed to put a IABP, and the consultant cardiologist comes and takes him back to the cath lab for this patient. And then they come back after an hour, says that there was another proximal LCX block. There was a dissection in RCA, which we have all stented, but the patient is in a profound shock. So now he's on, he comes back with an IABP, and he wants to talk to the family and make a decision about further care. So patient is still same numbers, but now he's on a lot of noradrenaline, IABP, and like now NORAD, he comes back on 30 ml. What else can you use? What other vasopressors that you could use for this patient?
For inotropic effect, we can use dobutamine, sir.
Okay.
Given in the situation, dobutamine has a hypotensive side effect, and we wanted to titrate between by using noradrenaline and along with the dobutamine. And if patient is not improving with the inotropics and vasopressor support, we wanted we initiate left ventricular assisted devices support, LVAD support, sir. And meantime, we wanted to involve cardiologist team, and also wanted to counsel the patient attenders regarding the high cup of mechanical support.
Yeah. So so what would be your escalation policy of, let's say, inotropic? Now we have said noradrenaline, and then you're going to add something that's probably a little bit more vasodilatory action. vasopressin. So we could do the same thing for all shocks, but sometimes you want to choose some other vasoactive agent like in this case dobutamine or levosimendan or milrinone for different actions. So all three have a different action. Maybe dobutamine and levosimendan are probably a closer than milrinone, which is a bit different. Yeah. So you have a purpose-built use for cardiology. So
but here the BP is too low. BP is too low. If it's a borderline BP, you have an elevated, filling pressures, borderline BP. You could have tried that. But here, when the BP is too low, I think it is going to be more detrimental. Let's go. BP is because of dilating effect of dobutamine. The BP is going to come down much, much significantly. More significantly, it's just going to come down. That's what concern. Dobutamine. Maybe we can try, but maybe we can try, but I will be extremely cautious at this point of time.
So I think these guys are in an advanced cardiac center. So I would want to hear what are the escalating mechanical devices. Now we start with IABP. What are the other things that you would do for this patient who is now in established cardiogenic shock?
So IABP said before that, I just want to know what is the role of IABP and cardiogenic shock?
One will
Especially myocardial infarction, just to know, because these are all very important from the IC point of view. What is the current status of IABP? Where will you use it?
diastolic augmentation and
All the cardiogenic shock will you use it? What the evidence says?
Sir,
bridge
in
to
IABP Shock 2 trial,
Yeah.
they tried along with the PCI intervention, they kept the IABP, sir. In this patient, there is no significant mortality benefit with the initiation of IABP. But in some patient after improvement, they could not define between improvement with the PCI intervention or improvement with the IABP initiation.
Yeah.
So there is no significant.
So routine use of IABP, in cardiogenic shock has not to make it any clinical benefit to the patient. That's what you're trying to say.
Yes,
So these are a mixed group of patients: ST elevation, non-ST elevation, myocardial infarction, even maybe in unstable angina. Those kind of patients who are in shock, these are the patients selected. So IABP 2 trial has not shown that there is any routine use is going to make a difference. So then where will you use IABP? Now, can you just give some minute just to give a message to the people? Where exactly you need to do IABP?
like in this patient.
No, see, IABP, in spite of whatever routine use is not going to make a difference. I mean, it is not going to help. We know that. But obviously, when the BP is too low, obviously, if you don't have any other options, obviously, other options are also there now. We are just entering there. But in those patients whose the perfusion pressure is too low, obviously the patient is going to other multi-organ dysfunction. You may have to give a try of IABP, that is for sure. But otherwise, what I want to ask you is that is there any definite indication? Is there a consensus indication for IABP in this situation, myocardial infarction? What I want to say that IABP is definitely indicated when you have a mechanical complication of the heart. A patient is on way to the CABG. Before the patient is going to the CABG, those kind of patients, there is no dispute. Other patient, there could be no dispute. When you have a mechanical complication of the heart, IABP is definitely indicated as a transient measure before the recovery or before whatever. Before you go for a CABG, on way to CABG to fix the repair. There is an indication definitely there. Or it has been some consensus opinion has been that in a patient who is rapidly deteriorating, maybe this patient, as Justin was telling, suddenly this patient has suddenly deteriorated. Patient is rapidly deteriorating, it is not under your control. So you put the patient on IABP. So these are the two things: mechanical complication of the heart on way to CABG, because there you need to go for a CABG as well. Then you fix the repair and CABG, both of you do. Or the patient who is rapidly deteriorating, maybe the patient which is be ended here. This kind of patient you can go for IABP. Now, once IABP is failing, I think you people are going for a left ventricular assist device. Is there any other thing? I know. Is there any other thing?
They are going to say the list. They are going to say the list.
I know. Okay. Okay. Right. Yeah.
Impala, tandem heart.
No, what about a single thing about? I don't know. I know you people all know the Impala is very, very extremely cheap. I know. Is there anything which is a little bit, easier before that? Anything possible? No. Impala, tandem heart, LVAD. I understand all that. Is there any other thing you can try?
V-ECMO.
Yeah. that may.
Yeah. So I think whatever it says, obviously.
Impala is only 20 lakhs. Yeah. So
No, I think like they are obviously working in an advanced cardiac center.
I know,
The
no,
impella
no.
use is quite high there.
No,
That's
no,
okay.
I'm not.
Yeah, yes, yes.
Yeah.
So I think for all practical purposes in majority of Indian settings, I think IABP and probably they'll go for a ECMO or a heart bypass based on what is required and continue beyond a bypass. And then if they are not able to come back or can't wean off, or the very rare cases in like you guys, if you have an advanced center, they will probably use impella, like various grades of impella. I think isn't it? Based on the liters that they use. So that's the thing. So we'll come back to maybe like Ajith was saying IABP. So some of these gadgets probably are within the realm of intensivists who's come for the exam. Maybe they won't know too much about the impella or other things, but they know ECMO, they know IABP, the examiners. So what is the mechanism by which the forward motion of blood flow happens with IABP? What is that word, technical word?
Sir, actually, the idea of IABP is to improve coronary perfusion and to increase.
So you have to tell me there is a technical word how the forward motion of blood happens.
Decreasing afterload and diastolic augmentation.
I know. There is a word for it. That's it. Okay. So yeah.
Intra-aortic counterpulsation.
Counterpulsation. No, what I meant to say is that ST elevation in the AVR more than V1 is a valence sign. So I'm looking for valence sign here. So read about it. Okay. So the mechanism how it sucks and moves forward is one thing that you need to know. So there are three things that happen with the IABP. So the one is that improvement in cardiac perfusion, like you guys say. Number two is that improvement in cardiac index. And the third and most important thing is that afterload reduction. Okay, so essentially majority of these functions are coronary perfusion is marginal. So I think everybody says that physiologically, but intracoronary studies have not been able to prove so much of a benefit. The cardiac index improvement is very marginal actually.
Yes.
Yeah, so the main action probably in these states for them is that afterload reduction. So particularly when you have a failing LV, that's probably where the most of the money is. So acute heart is not about improving the pump, but reducing the workload, whether it is for RV or an LV. So this is the overall, that's what is. So majority of cardiac failure patients you only give vasodilators. You don't give contractility agents. That's because for a failing heart, all you need to do is that don't push the heart anymore. Allow it to work less. So that's the reason why. So all those the failure of impeller device to prove conclusive improvement in outcomes is all because of that. So just because you improve cardiac index, it doesn't change unless you allow the heart to rest for some period. So that's the reason why those are the things. So we need to know IABP a little bit more. And in terms of examinations, they may even ask what would be some more things. I think it will come as a equipment station. So equipment station probably will have traces, and then you could do that. So those knowing the equipment. Okay. So let's, for example, patient is stable on let's say IABP, and you've started on noradrenaline, vasopressin, and the perfusion pressure is good. Urine output is poor for the last 6 hours for this patient, and then suddenly somebody says that we will stop for that period of time, and then I want to ask you utilization of equipment to optimize the care. So let's say you only had information about the blood gases for him, for this patient. You have only access to blood gases, nothing else. How would you use blood gases to titrate therapies for him? So now you need to tell me about patient's main problem is the shock, isn't it? How would you assess the shock with an ABG?
Okay. So we can do an central venous pressure as well as an arterial blood gas at the simultaneously.
Yeah,
And then-
excellent.
And then we can differentiate the type of shock to some extent, though not completely.
Excellent. Very good. Super. Yeah, that's good. So HCVO2 is a good, like, it's at least if you do it more than once, you will realize that it is a clearly 60% or less patient who's saturating above 92% in generally or reasonably oxygenated systemically is a clear cut say that there is a cardiac problem, significant cardiac problem. So, yeah, so that's good. Number one. Yeah. So diagnosis of shock, you could use the ABG with the central venous oxygenation. One. What else? Severity, obviously. Now we will see the pH wise acidosis or bicarb, whichever, and gap to tell you that what is the consequence of that shock. And lactates would come in it, so you will know that whether there is any consequence of the shock. Some of the ABGs will also give you the organ dysfunctions, like one creat will come, so whether there is a worsening, so you can progress the ABGs. So each equipment or each test can be used a lot more than what we use generally in your clinical practice. You have only arterial and what should you do? Or when you have only central and what would you do? Let's say example. So if you think about it like that in your general practice, then you will realize that there are so many things that you could do. So now I can ask you some of the anesthesia professors who come for the exam may suddenly stop and says that tell me all the measured and derived values of arterial line ABG.
So pH and carbon dioxide is going to be a calculated value. Oh, sorry, measured value, while bicarbonate is going to be a calculated value.
No, so obviously the clocks, which are the clocks probes. So there is oxygen is directly measured. Okay, then hydrogen is measured. Your pH and bicarb are derived. So the only three things that they will measure in most of the occasions is the CO2 probe, oxygen probe, and hydrogen ion. Yeah, and everything else is derived in that. So what is the commonest problem with your ABGs? It's always going to be CO2 probe. So when you're aware of these things, some of the things that you have in ABGs that come. So these are some of the basic things. Some of the professors who come from anesthesia would go on to ask, so they tell me what are all the salts there in noradrenaline? What are the composition of noradrenaline? Again, they go on a lot more in depth about the things. So but most of them are okay to pass the candidates because all they want is basic information. Yeah. So now we have had this patient for 3 days in the hospital, and on the day 4, just as you guys are doing the ward round, has a VF arrest. Patient's been able to be just weaned off IABP. He's on 3 ml of NORAD. He was on pressure support this morning. And he started to make 30-40 ml of urine, but suddenly has a VF arrest. How would you approach this patient?
Approach is again as per ACLS algorithm.
Excellent. Yeah.
So since the patient is having an ongoing VF with continuing ventilation, I'll shock the patient.
Yeah.
And if the shock is not revertible after with the ongoing CPR, if the shock is not revertible after second dose, then I'll consider giving lignocaine for this patient.
Excellent. Yeah. Excellent. Yeah.
And even after the third shock, if again the patient is not still having a persistent VF, and the second dose of lignocaine will be repeated. Half the dose of the lignocaine will be repeated.
Okay.
We look for
Yeah.
5 Ts during
Excellent. Very good. Yeah. Very good. So we want to do that. Essentially, what I'm going to say is that ACLS, Favigeston 5 Ts. So ABG and a quick echo or kind of EFAST, one of those things that you need to do, because that's the way you're going to address obstructive, mechanical, and other complications of this patient. So concurrently, you're going to initiate the CPR, because we don't just shock. We just start CPR. By the time you stuck the pads, it will take time. So your CPR will go on. You'll ventilate the patient, mandatory ventilation, 100% oxygen. So ACLS is a very, very important. I think Ajith probably will tell you that Ajith is a basic, ACLS and airway are basic competencies, not just in IDCCM exams, but also DNB exams, because the examiners are the same most of the time. Okay, they take it very seriously. So when you have an ACLS station, please make sure that you say some basic things about ACLS. Like you rightly said, ACLS. If you are given a trauma station, patients come to emergency, some major trauma, you say, I will assess the patient in keeping with ATLS principles. I will assess A, B, C, D. A good answer. Okay. When burns come, they also say the same. ATLS principles, and I will do it sort of. So that's exactly what we were trying to do, is that we will come up with a structured way of answering, because the minute you say that word, automatically it says. I have seen in exams, people will present to me, patient is prone ventilated. They are presenting to me, patient has a bilateral pneumonia and respiratory failure. And nearly 10 minutes pass, they have not said the word ARDS. The minute they use the word ARDS, then everything flows around. The mind is tuned to that. So unless we say code STEMI, nobody moves like as if it is a STEMI. So we are used to that, what is called the cognitive tags. So I want you to use that in your exam, so that each time you are looking for some emergency, ACLS, or I would do this 5HS5Ts. So that's generally based. So the minute examiner realizes that you're going to do a sequential assessment, okay, that's fine. What are you looking for here? They will ask. So this is what the examination is about. So now you are doing the ACLS. This patient has had, after some time, the shock is going on. You have a shock for 3 times. There is a rhythm coming. There is the ECG looks normal, but it goes back into VFs again and again. So cardiologist thinks that there is nothing active ischemia, continue anticoagulation, that should be enough. And then, so how would you manage a patient who's got what we call as a now refractory VF?
Firstly, with ongoing CPR. So I'll first roll out 5H and 5Ds again.
Excellent.
And as well, I'll roll out the electrolyte abnormalities to be specific, because the patient comes back to normal rhythm, again reverts back into VT.
Yeah.
That's this thing.
Electrolytes. Yeah.
And with ongoing CPR, if not able to revert and situation is still going into VF, I'll try to initiate eCPR as well.
Okay, eCPR, that's fine. So no, I think he's coming back, but he's going into VFs where he needs maybe 1 or 2 cycles of CPR and then stabilizes, and then suddenly has this, and it's going on for 2 hours. No cardiologist stands by the bedside, isn't it, for 2 hours? He'll go away. By the time he comes back, you've already reverted, and ECG looks normal, and it's like, okay, fine, just continue anticoagulation. We'll see how it goes. And so this goes on for 3-4 times.
I'll give a shot of magnesium.
Yeah.
And apart from the other ongoing CPR.
You have given amiodarone before.
Yeah.
And you have given 2 doses of lignocaine. Now you are giving magnesium. Yes. What else you do?
I'll start infusion of same.
Amiodarone, excellent. Yeah. And if let's say you've got more than 4 or 5 episodes of these VFs that need either a shock or a CPR, I know it's not common for us to see refractory VFs. So lignocaine infusion as well, yeah.
Yeah.
Yeah, lignocaine infusion. So lignocaine is becoming more and more important now. It's making what we call as it is making a breakthrough and coming even ahead of amiodarone. Some of that, I think I have a feeling it is gonna make a transition to becoming first line rather than like now where we are using conjunctively. So that's the thing. So now 2 antiarrhythmics are going on. What else? Obviously, this is an advanced care where you would get the help from the electrophysiologist or cardiologist to do something else about the patient, like a beta blockade or like something that reduces sympathetic system.
Procainamide can-
Yeah, so that's the thing. Procainamide and things like that. Yeah, so that's essentially what I'm going to say is that you really need to know the escalation plan for these patients. So you say, okay, fine, amiodarone, finish. And if you ask another question, then you'd be stuck if you haven't like thought through the second line. So for exams, that's all they want to see is that they will ask you one question more than what you're comfortable with. So that's the next step of most of the examiners' trick is that. So they want to make sure that you are fluent with the second line of steps. So that's so now that this patient has been resuscitated, let's say after nearly 15 minutes of downtime, ECG is good, and then shock is like marginally worse than before. And how would you manage this patient now, clinic, like in terms of what are the like plans that you would make for the patient now that like there is no more arrhythmias coming for like for 4 hours, like at least for some time now. Hemodynamically, like twice the NORAD dose than before, but you seem to be okay. So what are all the things that you would do?
Sir, I'll activate a post cardiac arrest care.
Excellent, super. So that's a post resuscitation care. Yeah, that's good.
And
excellent word.
yes, sir. Targeting normothermia and targeting normoxy and normocarbia, and maintaining adequate MAP and titrating noradrenaline according to that. And we see for pupillary response, and after 48 hours, we'll plan for brain imaging, sir.
Yeah. Okay. So, Ajith, would you want to ask him about the neuroprognostication or prognostication after cardiac arrest? Questions maybe.
Unmute.
Unmute.
Unmute, sir. Ajith, sir. Please.
Yeah. So
I'll just take a minute, 1 second.
Yeah. So what is the, so how long will you wait actually after the cardiac arrest?
72 hours to.
So prognostic and you wait for 72 hours. Yeah. That's fine. Yeah. So how will you examine the patient?
We'll assess the Glasgow Coma scale of the patient as well as the pupillary response of the patient. And EEG also can be supplemented by EEG and an MRI. 72 hours. Give us the prognostication, and we'll look for signs of seizure or any myoclonic jerks. Blood markers like neuron-specific enolase can also aid us prognostication.
So dilated pupils, basically no motor response at admission, and after 72 hours, basically is a very bad prognostic sign. And even in the myoclonic jerks also, generally it indicates that it signifies a bad prognosis after cardiac arrest. Can you hear me?
Yes, sir.
Yes, yeah. So MRI may or may not be able to show some kind of a hypoxemic ischemic changes. So basically, you can do an MRI. Maybe you may have to repeat it after around 7 days or something, after 1 week or something. The initial MRI could be even normal as well before you see that.
Yes, sir. Yes, sir.
So I would think that the neuroprognostication is always what we call as a multimodal. Okay, so prognostication is there is a binary prognostication, that means yes or no, or relatively bad, relatively good, or two ways of seeing it. Okay, for neuroprognostication. So like Dr. Ajith was saying, you are present you at 72 hours or more. If a patient has got brainstem reflexes, the more number of them absent, the worse it is. Like pupillary, corneal, cough gag, and spontaneous breaths, all these things. The more number of them absent, the 2 or more, that's a bad news. Myoclonic continuous status myoclonus, that's bad. Number 3 is that motor score without underlying seizure activity of M2 or worse. is bad. So essentially, these patients you could work towards active palliation. Okay, but everybody else, like an M3, M4, M5, you cannot prognosticate them that easily. So now it becomes a game of relativity. So now we want to prove that the more number of investigations or examinations that contribute to it, the worse it gets. Like say the patient is M3, but pupils are fixed and dilated, or bilateral, but EEG is showing a bad prognostic features, you still can palliate. Like you use more and more equipment, like I think to facilitate or improve your prognostication. It's not like bad MRI, bad outcome, nothing like that. So most of the time the problem is when a patient is M3, prognosticating M3 becomes a really bad challenge for us. So what I meant to say is that you really know bad prognostic features, and the patients who are not really bad prognostic patients are needing multimodal assessment. So the ECG, EEG, initially step 1 to make sure that there is no status. If it is no status, then you are looking to see if there is any bad EEG features. There are some bad EEG, like frontalization and some other features. So that changes are there on. Then the second commonest thing is that for us imaging, like high quality MRIs, not simple MRIs. And the third is that if you have access to biomarkers, you can do biomarkers. I don't. So those are the things that you use in a graded fashion to assist clinical examination. So that's what we are calling about prognostication. So you need to be clear about prognostication. So if the patient is M2 or less with more and more brainstem reflexes or status myoclonus, I would work towards a palliative care process. So you are very clear. And most of my colleagues are clear about that. The patient is M3 and over, I would use not only you, a second clinical examiner to assist you, like a neurologist or another intensivist, one clinical examination backup. You use the EEG, you use the MRIs, you use the biomarkers and some other things. So you use all of these things to put together and come up with the prognostication. So that's called neuroprognostication. Most of the time when these cases go on, at the end, some of the stations where they say that there will be a quick communication station. Quick communication station. They will only be like 2 minutes, like 2 or 3 minutes. It's all based on how the scenario has gone for the patient generally. But there will be one in one of the 2 main cases, or if it is only one main case and others are small cases, the main case will have a 2-minute communication. So they will ask you to say, now the wife has come and I want you to tell her that his prognosis is bad, or brain death, or impending brain death, something like that. So can one of you try tell me, like, think of it as I am the wife of the patient, and you're going to tell me that he's got, like, let's for example think that he's status myoclonus, pupillary dilatation, and all your colleagues said he's not going to wake up. Now you've got to tell me that. So you've got 90 seconds to start the conversation about how you go about.
Actually, first thing is spike model helps in this conversation between the breaking a bad news. And initially we have to setting up the scenario and away from all the distractions, and we need to know the exact information, at what level they know the information regarding the patient status and what background they know, and then followed by revealing the information in a gradual manner. And if patient attenders were not at a state to receive this bad prognosis, involving a multidisciplinary team and revealing in a stage-wise manner would be better comparing to directly telling breaking a bad news.
Yeah. So that's exactly like, you know, so again, tag words, excellent. So you said breaking bad news. And then you're going to spike model. So the two things, essentially examiner doesn't need to hear anything from you because he realizes you're going to do something at least quite decent in terms of communication. So that's essential. So identification, like, you know, this is a code STEMI. So you identified the scenario as a breaking bad news, which is excellent. Half the time people don't do that in the exams. So whenever somebody says something, you are interpreting what is my scenario, what is my role here. So like, you know, patients got a hypotension, now new hypotension, what are you going to do? What is my role here as an intensivist? So this is exactly what you have done. Excellent. So essentially I would say, I would introduce myself, or as you say, examiner said, this is a breaking bad news. I generally follow Spike's protocol. And then I introduce myself to the patient, introduce myself. So I am Dr. So-and-so, I'm looking after your patient. I've examined him today. I'm going to talk to you something back about the patient. Are you okay? Are you okay? You're on your own? Or do you need somebody else to be with you? Make the sit, like you said, environment, quiet, private room, a social worker or support staff if needed, the nurse to sit with her, or if the family is there, they can sit with her, things like that. And then you're going to go through the history. So generally they will stop by this time, examiners will stop. That's fine, like, we'll go ahead. Yes. So this is what is called as a communication, which obviously when you're practicing for communication station, you will take it forward next. But what I'm going to say is that that's the start of the station. It has to be that you say how you're going to approach, and then you start the station. And that's what examiners are generally looking for most of the time. Whatever I've seen, DNB exams, not FNBs, just the last DNB exam also. This is probably what is happening. So, one of the main cases will have a short communication station. Yeah, so you got the point now. So majority of the things in today's exam is either using more information to synthesize something, or answering in a structured way, or triggering a tag word so that your answers are more easier. So that's the 3 take-home points for the exam preparation. If you have any questions, both me and Ajith are okay to answer. And then maybe Dr. Madhusudan could debrief all of us maybe. And we took a long time. I'm sorry. I think we ran over time, I think. Yeah.
No, that is quite interesting. I think since inception, a lot of points have been discussed and emphasized for the people students to present in a systematic way. And I think the important message for both of the students is important. Whatever the questions are asked, we have to give a structured way of answer is important than giving haphazardly. I think still the discussion going on. Actually, the time of discussion for 1 hour, but more than 1.5 hours is going on. I'll just go to the questions in the chat box, which are their questions. Some of the questions we covered, some of the questions are not covered. One of the question is there about, we talked about the lignocaine infusion. What is the dose we are going to use for lignocaine infusion?
And I'm pretty sure, I think most of us will look it up online, isn't it? Like, nothing comes up.
No, I agree.
We all probably look it up rather than trying to remember so much information at this point of time. But I would think that there is a set infusion rates that are fluctuating between so and so. So most of the time when you need lignocaine infusion, you would already have either a EP physician or a cardiologist along with you. So majority of the time the decision is more shared.
So you give a bolus of around 1.5 milligram, if my memory is correct. Maybe 1.5 milligram per kilogram body weight, you give a bolus. Then I think the infusion, we have to check it, because we also prefer to check the line, because the error is going to be less rather than telling from the memory.
Yeah. Sorry for that.
Another thing is ACS, prognostic score. So basically, So as far as I know, there are two scoring systems. One is the TIMI score, actually, thrombolysin myocardial infarction, TIMI score. I think there is difference from STEMI and non-STEMI, and there is something like a gray score also, depending on the adverse reaction, the adverse events which is expected, and the mortality. I think the student can, because I don't, routinely manage, cardiovascular patients. So basically, student can just check it actually, in the sense what I mean to say that, the gray score and the PIMI score.
Yeah, we use the gray score very frequently. So essentially, we use that predominantly in patients who's admitted with NSTEMI to deciding how quickly we send them for a PCI. The minute the gray score starts increasing beyond a certain point, because that reflects 90-day mortality for them, essentially, that's what it says. The higher the score, the early they go for PCI. So the nights the patients gets admitted with an NSTEMI, cardiologist will say, we'll see them tomorrow, or they'll send them to the ward. We'll discuss with the patients and do the angio later. But there are times then you really have to do the score and push for them to do that angio like within 12 hours or within 24 hours. So for that reason, we use gray scores very commonly in terms of for assessing a patient for a PCI, particularly in NSTEMI situation, not STEMI.
Yeah. And another, another question is about the spike protocol. Yeah, I'm not very sure about the spike protocol, but I think I can just see that it's a setting up an SC for setting up and starting. Then perception, I'm not an expert in that. Invitation, knowledge, I think anybody can Google and see. And E for emotions, S for strategy and summary. So Justin may be knowing that. I'm not very sure. I'm not used to this.
Yeah,
spike protocol breaking the news.
I think we all when we were training in Australia, these are all some of the things that we really have to have handy. So at the end of the day, it's all about having a patient-centered or a family-centered or a combined reflective communication. That means there is a communication that is reflective. That means, do you know enough? I'm telling you this. Did you understand? I'm going to talk to you more. If you are not able to get back to understand me or you're having trouble with me, I can get somebody else to talk to you. So this is essentially the whole idea about the spikes protocol or reflective communication. So you can practice that on a day-to-day basis in your IC. I can tell you it will do wonders for you. After some time, you will realize that it just a lot more communication wise. It's a bit difficult in open ICUs because the breadth of information that you can give is a little bit difficult, but at the play, at least in the cases where you are holding the majority of the communication, you will find it useful.
Yeah,
and it's a good for exams though, at least.
Yeah. So do we mention about IVAD devices in cardiogenic? I think cardiogenic shock. IVAD device. LVAD. Sorry, I'm sorry. LVAD. Yeah. Yes.
Yeah. That's.
So you can have basically you can have a left ventricular assist device, and you can have biventricular assist devices as well. And obviously the LVAD is definitely some of the newer LVADs. You can use it even for quite a longer time. Usually the LVAD is definitely used as a bridge to recovery or a bridge for transplant. Unless if you're going for a heart transplant, something has to be really reversible. It's only a supportive therapy. It's not going to cure anything. So that is what it is. And obviously all this among these coming other tandem heart and response assist devices. Tandem heart is from the femoral, from the left atrium to the femoral artery. So you have the connection is from the left atrium to the femoral artery. The connection is there, but this Aster device is basically only as a bridge to recovery or transplant. We can definitely use in cardiogenic shock.
Yeah.
One more question is there about the ACS with ischemic stroke, role of reperfusion strategy.
Yeah, so at the end of the day, when you have thrombus two different places, one, obviously the priority comes on which is the most life-threatening. So if you're gonna do reperfusion, you could thrombolize the patient and that would affect for both. But if you think that there is a higher risk for, like, let's say your NHS score is too low or too high, then you would probably choose to do like in a PCI. Let's say your NHS score is 6 or 4, but you have MI, proper MI. And then at that point of time, whether you, and if it is not associated with AF, you probably will do a PCI with a more a bare metal stent rather than like a higher anticoagulation and therapeutic anticoagulation, things like that. So those decision makings are fine. So like if you have thrombolysis window, like NIH score 6 to 24, and you have a ST elevation MI, you could thrombolyze the patient and you can still take them for rescue PTCA, and probably limit your antiplatelets to certain amount. Whereas if your NIH score is 24 and above or 26 and above, whichever one of those things on MCA is big, giving 2 antiplatelets is also going to be a problem for them. So then
Yes. Yeah, that's the thing. Yeah. So that's the thing. So if the ischemic stroke is in the last 3 hours, within the last 3 hours, so obviously you can thrombolyze the patient. That is the message. If it's happening within the last 3 hours and you have an MI, is there, and the ischemic stroke has happened, in the 3 hour period, you can thrombolyze the patient.
Yeah. So hopefully I know it's a bit vague, I'm sorry, but you could always make sure that which is the most life-threatening. Like you have an MI with a cardiogenic shock and you have an NIH score of low, then you address the heart more. Or if you have a thrombolytic range, then you probably choose the thrombolysis plus or minus PCI. It doesn't matter at that time, as long as you are aware of the risks of poor anticoagulation. So you may choose to use only clopidogrel rather than ticagrelor at that time. Things like that, some optimizations. And rather than using therapeutic anticoagulation, you probably just use DVD prophylaxis at that time, as a bare metal stent rather than a drug-eluting stent, which needs higher anticoagulation, things like that. So those optimizations can be done, but most of those things are collaborative decisions and probably isn't necessarily so complicated for the exam. And somebody's asking you these things in exam, that means that you have gone through a good range of basic questions and you're well in advance. So most of the time what they do is that they probably, one of the things that we did not do and probably was partially did is that like IAPP trial. So they may ask you something about the evidence, like tell me what is the evidence for noradrenaline. So rather than asking you to say complicated clinical scenario like when you have an MI and the ACS or a stroke. So this is what generally the examinations that the examiners would tend to do.
So within the video period, we can thrombolyze. Then obviously, as you rightly said, we can make a consensus decision. We can work with the PCA the coming hours.
Yeah.
I think thanks a lot, Ajith sir and Justin, because a lot of information has been given. Not only we covered the topic about the ACS and cardiogenic shock, I think we discussed a lot about the pre-hospital care, if the PCI capable center or not, when to do a basic investigations just like an ECG, what are the various criteria are there, their complications, their medications, their doses, and at the end we seen about the cardiogenic shock, and at the end when the patient getting in complications and end of life care. I think it will be a lot of useful for the students which are going exam going, so that it is not the case what case you are getting ACS or cardiogenic shock. The discussion will not go on for the topic, may go a lateral discussion also, as I think during the discussion Ajith Kumar and Dr. Justin has mentioned, the discussion can go to anywhere. It is not necessary the case is there, the basic case will be taken and subsequently we'll have the discussions. I think more than 70 to 80 people are online joined, and lot many more people will be seeing over a period of time. Thanks a lot, Dr. Ajith Kumar sir and Justin, for giving your valuable time and giving the valuable guidance for the students. Thanks, Dr. Vignesh and Dr. Udaykiran for presenting a good case. I think,
thank you, guys.
Thank
Thank
you.
you. Thank you, guys. Thanks for the opportunity. We're happy to engage. Yeah.
Thank you. We'll meet you soon. Thank you.
Thank you, sir. Thanks.
We'll meet
you. Session for today.
Thank you, sir. Thanks.
Thank you. Goodbye.
Thank you.
Good night.
Thank you.